Okay, so moving right along, thinking about multiple drugs, I'd like to invite Dr. Scott Cameron to talk to us about atrial fibrillation and acute coronary syndrome. How many antithrombotics and for how long should they be treated?
Okay, thanks so much, Jeffrey. Okay, so we are at 4 minutes 57. We've not connected yet, so I'm just pulling the rip card and we're connected. So I don't have any disclosures. What I would like to kind of go over with you, though, is to try and distinguish anticoagulants from antiplatelet agents. Sometimes I think if we put them together as antithrombotics, it can get a little bit confusing. We'll talk about the guidelines for anticoagulants for atrial fibrillation, atrial flutter, and then antiplatelet agents for the purposes of acute coronary syndrome, and then talk about overlap therapy, which is the title of the talk. So for acute coronary syndrome, as you know, if somebody has an event, irrespective of whether they get percutaneous or even surgical intervention, you have to give them dual antiplatelet therapy for a minimum of 12 months, and that's a class 1 recommendation. And after the DAPT study, things got a little bit more interesting because certainly we do keep some patients on DAPT longer than 12 months. Certainly that's something that I do, but those are the guidelines. In terms of atrial fibrillation or atrial flutter, as you can see here, there's a patient of ours in the CCU. They've got atrial fibrillation. If you look at the arterial trace, which is of course ventricular, the arterial contour is not static. You see that there's vortices and disturbed flow there. That's a nidus for thrombosis, and I tend to take cardiac thrombosis very personally because they cause embolic events in a lot of cases and strokes, which we don't want. So according to the guidelines, if it's non-valvular atrial fibrillation with a CHAD-SWAS-2 score of at least 2 or even 1 is reasonable in some cases, you should be putting the patient on either a vitamin K antagonist or a direct oral anticoagulant for life. Now, valvular atrial fibrillation is a little bit different. You can see here, this is the parasternal short axis. You can see the anterior and posterior leaflets there are almost fused. This is a patient of mine that has rheumatic heart disease. And according to the guidelines, there are some interesting studies saying that you can use DOACs, but for the most part, you're supposed to use a vitamin K antagonist. And so the interesting thing is about 30% of patients with atrial arrhythmias will at some point have an acute coronary syndrome. And so because of that fact, you have to consider should you keep patients on triple therapy for a long period of time or not. Now, there are other indications beyond the scope of this talk, such as if there's a prosthetic cardiac valve or venous thromboembolism, they'll also find themselves on anticoagulants. There's also clinical variables such as peripheral artery disease, diabetes, chronic kidney disease, and chronic coronary artery disease. These are very thrombotic states, and I'll tell you, the platelet phenotype is just not the same in these diseases. And then there's anatomic considerations such as stent length, such as the complexity of the lesions, and caliber of the vessel and such that could make them more risk for having coronary thrombosis. This is a kind of simplified diagram I use for the medical students for teaching purposes, just to highlight that there's really 4 medications, 4 classes available by mouth for blocking the platelet, starting from the least potent, basically cilostazol, pentoxifylline, or phosphodiesterase E3 inhibitors. And what they basically do will increase cyclic AMP inside the platelet. So for the most part, if you want to inhibit the platelet, increase cyclic AMP. If you want to activate it, increase calcium from the endoplasmic reticulum. Then moving a bit more potent, you've got aspirin, which will inhibit cyclooxygenase, so you'll get less thromboxane A2 produced. That will have less activation of the thromboxane A2 receptor. And then getting even more potent, you've just moved further down to the most potent, whereas we've got second most potent is a P2Y12 antagonist. So the P2Y12 receptor is negatively linked to adenylate cyclase. So if you activate it, there's less cyclic AMP, so the platelet gets activated. If you use an antagonist, cyclic AMP gets increased, and so you'll inhibit the platelet. And then there's the PAR1 receptor antagonist, Vorapaxar. Now, anticoagulants we spend a lot of time thinking about, vitamin K antagonists, 10A inhibitors, and direct thrombin inhibitors. You can see in the pathways where they inhibit, just a reminder to this audience here, that they do in fact indirectly or directly inhibit thrombin. Thrombin is, in the lab that I work in, it's a really, really potent platelet activator. It'll activate both PAR1 and PAR4, so you've got to consider that. In terms of the studies I've looked at overlapping dual antiplatelet therapy and oral anticoagulants, there's basically 4 of them. I don't have time to go through all 4 of them, so just talk about the ISAR triple study for one, which basically looked at patients that had percutaneous intervention. They were either on an oral anticoagulant, probably because of an atrial arrhythmia, and they were on dual antiplatelet therapy consisting of either aspirin and clopidogrel. They looked at 2 arms. There was a 6-week overlap of triple therapy, or there was 6 months. And the combined endpoint was death, MI, stroke, stent thrombosis, TIMI major bleeding. There was, in fact, no difference in the clinical outcomes, irrespective of whether you used 6 months or 6 weeks of triple therapy. And in fact, there was a signal for harm. Now, we're actually really fortunate because just last month there was a meta-analysis that looked at all of those studies that I just showed you. And what they basically looked like, at all the combined endpoints, there was overall a twofold increased risk of bleeding if you use triple therapy consisting of a dual antiplatelet agent, aspirin and clopidogrel, and an anticoagulant. And there was also, if you use triple therapy, an issue where you've got to interrupt the therapy and then you have thrombosis in a patient who started bleeding because you've given them 3 agents. And so overall, I'll tell you, based on the data and what I do in my own practice, I think triple therapy is probably excessive. And clearly, we know that P2Y12 receptor antagonists are much more potent antiplatelet agents than aspirin alone. So it's probably okay just to use that plus the oral anticoagulant. Then the question comes, what do you do after a year? And then just some other reminders, the new drug-eluting stents that we have, actually, they're less thrombogenic, and actually you can take patients off dual antiplatelet therapy sometimes less than 12 months. And so those are basically the data. Thank you so much.